talk of this morning. I'm Chen again. Okay. This topic I will talk about the gallbladder and should be general urinary system, because I also talk about the renal, bladder, and the most important, testicle in pediatric patients. Why we use ultrasound? These pictures demonstrate obviously the indications, right? When you see this kind, maybe hepatobiliary problem, but if that is caused by some obstruction, ultrasound can help to identify that kind of obstructions. So this is the first indication when you are trying to apply ultrasound to scan for the hepatobiliary condition. The other situation should be right upper quadrant pen to find out is it any cause. Normally, the lesion inside the liver should not cause any pain unless it is expanded or got something ruptured. So the main focus should focus on biliary system. That's the main goal of the ultrasound. So we look at the anatomy and some kind of, this is anatomy. So the gallbladder is just hide behind the liver. Sometimes it even higher, especially in the adult patients. So the gallbladder got the cystic duct drainage and then combined with the common hepatic duct to form the common bile duct. When we scan these areas, we may identify gallbladder, liver, and sometimes the duodenum cause some kind of gas mobile situations can sometimes cause confusion. Why? When the gallbladder contains fluid, it looks like gallbladder. When the gallbladder contains some kind of gas, it will interfere with the stone, so it may cause some kind of confusion and problem. This is the ER GB, so we can look at the detailed situations. All of you familiar with that, so we give a brief introduction. So when we look into the hepatobiliary system, we have to have some kind of brief introduction of the anatomy and then sonographic appearance of that kind of structures. We got vascular systems, IVC and hepatic vent, and we also got another important vascular systems, portal systems, divided into left branch and right branch. The left branch, when we look like, just like an English letter I, the capital I, look like that. And if you are interested in scanning different log segment, you can use that the vascular distribution to identify each of them. Just like I am not interested in separating into different segments, so I just separate by left lobe and right lobe because I only need to find out the problem. I'm not a gastroenterologist. I don't need to find out the S1, S2, S5, or S7. And then this is the gallbladder. So we got two cartoons inside our hepatobiliary system. The first one is Playboy. What is Playboy? The Playboy, that means our IVC and our hepatic vent. Normally we can see two. Sometimes you can see three. Left branch, middle branch, and right branch. But sometimes, most of the time, you see only two branches at one scanning. So this is IVC. IVC is useful not only for to identify the structure, but also when you are trying to figure out volume stages or shock. Cover the topic discussed tomorrow. It is also useful to identify this structure. When you see that, you know that Playboy is IVC and hepatic vent. The other cartoon is Mickey Mouse. What is Mickey Mouse important? Mickey Mouse is important because it is presents the portal triad. Sometimes we have no difficulty to identify the gallbladder, but almost we, especially for those novice practitioners, we have problem to identify the CBD, common bile duct. So if you are trying to figure out where is the CBD, find the gallbladder and trace down the founder's body to the neck, follow the mandibular feature to identify this structure. This is our portal vein. So in this short axis, you can see the CBD portal vein and common bile duct and hepatic artery in these sections. In another longitudinal sections, maybe you will see an olive in sandwich. The olive inside is hepatic artery, and this is Mickey Mouse. So this is our gallbladder. So when we are trying to figure out where CBD is, you just find the gallbladder to search for the long axis, the longest part of the gallbladder, and then trace down to the neck. You can find obviously the largest tube, that's portal vein. So try to figure out the portal vein in short axis and long axis. In short axis, it will demonstrate a Mickey Mouse figure. In long axis, we will demonstrate later. So gallbladder and the portal vein, we rotate the probe and you create a Mickey Mouse field. And when we are trying to rotate into another direction, portal vein, hepatic artery, and common bile duct is upper, just like us. Especially when the CBD is dilated, it's like all of it inside the sandwich. So the gallbladder, the Mickey Mouse, and rotate CBD, hepatic artery, and portal vein, hepatic artery, and the upper part is CBD. It also contains some sludges and tiny stones. This is a hepatobiliary system. When you put the probe transverse just at the upper part of the subxiphoid area, you will see this eye shape. This is our left branch, different from the hepatic vein. Hepatic vein, the outer is darker, not lightening. But here, for the portal system, you can see the outside of the border of the portal vein brighter, hyperechoic when compared to hepatic vein. That's because that contains inside the portal triad, so the out border will become brighter. This is eye shape. If you are interested, the segment 2, 3, and 4. This is transversely placed. And when we put the probe toward our right shoulder and deeper, as you can see, 15 centimeters, we can identify the right lobe. It should be hepatic vein. No bright border. It is portal vein. And then these two views got from the right side, coronal view or intercostal view to get this. Because sometimes it is easier to scan the gallbladder at the subcostal view, but sometimes you encounter the problem, especially for those obesity patients. So sometimes you need to scan that intercostally from the right areas. The upper part, we can see the diaphragm, the gallbladder, and the right portal branch. Where is the CBD? Gallbladder trace down portal vein, so you can see the tiny tiny, a thin black tube here. That's CBD. Normally it's very small, but when you can see two parallel, just like Shogun, when you see the Shogun or parallel, that means the dilatations. It is not difficult. It is difficult to define actually the dilatation of that tube structures. Why? Because the pediatric patients from the smaller one to the largest one, you have to memorize the numbers. This is difficult for us. So I think it will be easier when you see two tubes in similar size. That means dilatations. It will be easier when you encounter pediatric patients. For adult, it's easier. 7-11. Non-operated, we just remember 7 millimeters. For those operated patients, got cholecystectomy, we remember 11. But for the pediatric patients, I think it will be easier to visualize tubes. So when we scan the lower part, it is our kidney. When the first part we are talking about liver, the second part we will talk about liver. So you can see when this liver echogenicity is identified as isoechoic, the kidney, the cortex part should be darker, hypoechoic compared to the kidney liver. And the central part pelvis should be brighter without internal black echogenicity. It that kind of structure disruption or change, that means some kind of problem. The measurement is also important. For the gallbladder, we measure anterior part. This is gallbladder. For the posterior part, the outer margin will become not so clear because of the bowel loops. So when you are trying to measure the thickness, measure the anterior part. And for the CBD, common bile duct, we measure the inner part. If you measure the outer part, you will become overestimate. So it is important to remember that. For the pediatric patient, we also remember the 3 centimeters, 3 millimeters as a reference number. The difference between the stone with acoustic shadow and gas with dirty shadow. Sometimes you need to identify the clear margin of the gallbladder. And position change can help you to identify some problem, just like this view. We cannot see very clearly of this view, or is this impact or mobile. We just change the position. Erect or lie into left decubitus can make the mobile stone change, that we can see that is not impacted to cause the problem. And then we have different kind of pathology inside the gallbladder. The tiny stone, it is easy to miss. Why? No obvious shadow, because that's very tiny. Too tiny to cause the shadow. If the stone becomes larger to block the echo signal, then cause that kind of shadow. But if the stone is composed mainly of the cholesterol, it will not have brighter surface, right? So you can see that stone is different from the calcium stone. This kind of pathology is composed with the sludge. It's also like a pathologic finding. Then this field is easy. Most of the time we will miss. Why? No bile juice inside. Instead, it creates a typical pattern, double arc or wall echo shadow. That means the gallbladder filled with all the stones. So you cannot see the clear image of the bile juice. So this is the gallbladder wall, and this is filled with the stone. It's also kind of pathologic finding. We sometimes to observe the gallbladder. When the gallbladder wall is thickening, sometimes it's pathologic, sometimes it's physiologic. After the meal, the gallbladder shrink and the wall become thick. That's physiologic change, not pathologic. Sometimes the wall thickening because of other problems such as hepatic failure, such as uremia, hypoalbuminemia, cirrhosis. All of those conditions is not cholecystitis, but that will cause the gallbladder wall to become thickening. So the thickening is not a pathologic finding. But if you see the gallbladder into multiple layering, instead of triple layer, into multiple layering, that's specific for pathologic finding instead of idiopathic change. So the ultrasound findings of the acute cystitis, we know the stone patterns. Sometimes it's easier to find that. But for the pediatric patients, especially those for sepsis or operation or burn or something like that, or even the premature, some critical ill children, pediatric patients, the causes of cholecystitis may not be because of the stone, because of the critical ill condition we call it uncalculous cholecystitis. So despite this is the major signs we will observe, some kind of other specific findings like idiopathic change of the gallbladder wall, gas in the wall, or even echo-Murphy sign. It is obvious when you put the probe, you see the gallbladder. When you keep the deep breath, the gallbladder is just under your probe. You put the pressure, and that's not blind echo. That's not blind Murphy sign. It's very obvious. Visualize the echo-Murphy sign, right? So echo-Murphy sign is more positive, more meaningful for the traditional we do the precise way. The other rest, like pericholecystic fluid or overdistended, that's also findings you will observe when you scan for the acute cholecystitis, just like this video, or echo check. This is gallbladder, full with stone and echogenic maybe sludges, right? Some stones, some sludge, but no clear black biojuice inside. We measure anterior wall, outer to outer. And in this patient, we can see the other type, also severe type. You see the wall is thickening and multiple layer. And even the wall got sludges, and even the wall is disrupted into different kind of views. That's not sludge. Some stones, some sludge. And in the severe acute cholecystitis, you will have this kind of findings. The wall become thick and irregular shape, and even trying to become gangrenous change. Some fluid, black fluid around the gallbladder, and most of important, you see the probe, the gallbladder. When you put the probe in, you also elicit the positive echo Murphy sign. So stone, distended, thickening, positive echo Murphy sign. The diagnosis is very clear. You can also measure the common biodiameters. If you are trying to find out the CBD, I mentioned that with scan from the gallbladder to neck and to identify the portal vein, then you got the landmark to search for the CBD, just like these patients got right out of the okay? Kidney, the gallbladder and portal vein, hepatic artery. Then, when the tube is dilated means that filled with fluid, it will be easier to trace down. You can see this is duodenum, this is pancreas. It's almost near the ampulla. So we have hyperechoic with shadowing at near the opening of the ampulla. The duodenum, you can see the peristalsis. So when the tube got obstruction, no matter it is CBD or it is our ureter, when it is obstructed, got distended, if filled with fluid, it will become easier to observe. This kind of situation may encounter in pediatric patients. Choledochal cyst. So if you know the cyst, the duct should become smooth. In different situations, when you see abnormal dilatations, you should consider choledochal cyst in pediatric patients. Just like this kind of images. This is gallbladder and down the neck to CBD. You can see abnormal dilatations. I have no typical and clear video of this kind of disease. Sometimes you will encounter fever and pain and happen to find out this kind of situation. Inside the liver, the blackboard is here. This is left lobe. I can see left lobe. So we can see the hypoechoic, even mosaic patterns without clear shape. Because when we scan for the cystic or some lesions inside the kidney or our liver, we should identify the content. It is not smooth with echogenicity. And when we encounter this kind of situations, you should incorporate it into clinical scenario. Fever, gut pain, gut leukocytosis, the diagnosis should be clear. And the other part is, you can see, in adult, we observe this kind of situation all the time, many times. But in pediatric patients, it's about 10/5 or even less in pediatric for smaller children. But for those teenage, the situation may become more prevalent, maybe. So when we encounter this kind of situation, we may scan for gallstone, the renal stones. And then I think for the pediatric applications of the ultrasound, the most important is to determine the bladder volume. Not to calculate it is 1 100 milliliter or all the actual number, we want to answer one question. If I am trying to catheterization, is there any urine inside? You don't want to encounter embarrassing situations. Put the catheter in, no urine get out. Everybody just look at the tube. What's going on, right? Place that, return, wait for the urine or remove immediately. So we need to define this. And for those smaller children or those difficult to place the catheter, sometimes you will do the suprapubic aspiration. If you can identify exactly the position of the bladder, it will be safer and more comfortable for you to do the suprapubic puncture. You don't need to do it in real time. If you want, you can, but most of the time, we scan for the bladder to define, okay, it is a distended bladder. You define, mark the location, you do the puncture and aspiration. Okay, the job is done, everyone is happy. Then, renal failure, especially for those critical years, especially in the ICU. Ultrasound can define different kinds of renal failure, pre-renal cause, intrinsic and post-renal cause. But most of us, it will be easier to identify post-renal cause. For the pre-renal cause, you have to determine the volume stages. You have to scan other problems. For the intrinsic, you should look at the detail of the cortex and the medulla and the relationship between them, and even to use the choledochal. That's kind of comprehensive scanning. I think that is not belong to our initial experience. So for the positive renal cause, it will be easier and got immediate impact for those kind of emergencies. We all familiar with this. Ultrasound can use to scan this. If the bladder is distended with urine, it will be easier to identify. For the ureter, it is difficult and impossible to scan in normal situation, but in pathological dilatation, ultrasound can be used to trace down. My experience is that it will be easier when you encounter hydroureter. It will be easier to scan for the upper third part. For the lower third part, because it travels down to the pelvis, it will be difficult for me to scan that. But for the upper part, I have 90 to 95% successful rate to identify the obstruction place and site. And the kidney got a lot of structures around. So if you are trying to scan for the kidney, try to scan for best window. The right part, you have a great window, liver. For the left side, you have the spleen. So if you have difficult to scan on the left side, maybe you will put your probe to the left back to get a better view, like this way. So you can observe anterior, laterally, and even posterior for the right kidney, but for left, maybe posterior, or even your probe is closed and rest on the bed. If you are trying to measure, the measurement is also a problem. For the adult, the longest part, the average part should be 10 centimeter, and depends on the size of the patient. But for pediatrics, the same, smaller one to the bigger one, it would be difficult for us to remember the actual size. But when we are trying to measure anything, trying to measure the actual length, just like this length, instead of this is underestimate. So you have to scan for the longest part of that structure. This is the kidney. This picture, some of us will confuse for the hydronephrosis. Some of you will diagnose as mild hydronephrosis. When you have difficulty or confused with the problem, you can use, if you're a machine equipped with Doppler function turning on, and you can see that this kind of pelvic dilatation to prominent vessels instead of hydronephrosis. And then down to the bladder. This is our bladder. You can use transverse and anterior, posterior, and different dimension to calculate that. Use these 3 dimension and plus 0.75. You can have a rough volume of the urinary, the urine volume, but accuracy is not so good because the variation may up to 30 to 40%. But this number, I think you should remember when you are trying to define if this consideration will be successful. Remember this number. Put the probe in a transverse way. Measure the dimension. If the diameter is more than 2 centimeters, that means the volume should more than 2.5 milliliter. It will be okay for you to send for the specimen to some of the examinations. 8 years old boy got right abdominal pain. So if you are trying to figure out your focus problem, just like when you are trying to figure out right side abdominal pain, that's a big issue. Because the pain can cause from the liver, gallbladder, intussusception, the colon, small bowel, and kidney, and even ureterocele. If you are using ultrasound to find out what is the cause of the pain, it will be difficult. If you are trying to figure out, okay, right side pain, I use the ultrasound to find some fluid, use fast way, and try to find out hydronic forces. So if we are focusing on hydronic forces, this is kind of long axis of normal kidney, and this video shows the short axis. Have a good habit when you are scanning a target, scanning different ways, especially long axis and short axis. For the kidney, the long axis is not this line. It's a little bit oblique because you have to scan in kidney's way, just like in heart. You should scan the long axis of that structure. This is normal kidney. In comparison, this 8 years old boy. So you can see that the problem is the right side hydronic forces, and even we can trace down to proximal hydroureter. Just tampering, no obstruction inside. And then the transverse kidney, the collecting system, the hydronic forces, and get out the transverse view of the hydroureter, just near the IVC. And sometimes we will encounter structure abnormality, especially in pediatric patients. The frequency is even higher in adult. In pediatric patients, sometimes we will encounter this kind of special situation. 13 years old girl got right abdominal pain and fever. See this unique and specific structure abnormality. Scan the bladder, transverse view. Can you see here? A poaching here. Some echogenic particles inside it got mobile movement. The longitudinal way, the bladder, and here, can you see it all poaching inside the bladder? What is this? Ureterocele. An outpoaching of the ureter, poaching into the bladder. See again, because it is unique. I only got one video. Bladder, transverse view. A cystic outpoaching inside. This is the, can you see the connection of each two? Here. When we rotate it into it's uterus, bladder, and to the right side of her body, we can see this outpoaching and fluid inside and out. It's difficult to identify at the first encounter because I have not seen that before. So I scan a lot and try to figure out what's going on and to see the poaching, right? To find the pattern, but at the first encounter, I can name the abnormality. I don't have much of the experiences, so I recognize the patterns and to find out what's going on. So we will arrange the CT scan because that's kind of problem. It is unique and have some problem. I do not show the other side. The right side also got abscess. So it is the CT scan of this girl. We need to arrange different phase. This is the dilated ureter, hydronephrosis. Here, this is the problem one. This one is a normal one. So this girl also got duplicate ureter. And then the problem one also have a ureterocele, just like this one. So if you are trying to find out a problem, you'll be okay, use any kind of equipment. If you are trying to get better image, get better equipment. The previous video I recorded using our own machine in our ER for the age is 13 years. This one belongs to the pediatrics. They got better machine, got better quality. Okay. So then we can identify some kind of problem incorporated into this one. This is not a pediatric patient, but I will demonstrate to you the right side kidney. No hydronephrosis, but instead hyperechoic with shadow. That's kind of renal stone. Know the pattern. Then the other side, dilated. The calyx is dilated. It's difficult to see the cortex. It is severe, and you can trace down and to see the hydroureter, and even you got the chance to identify the hyperechoic structure with shadowing. So the problem is easier to identify if the structure is dilated, just like the one I mentioned in CBD and this one in hydronephrosis. And remember that the dilatation should contain clear fluid, no matter it is urine or bile juice. But if the content is increased, that means some kind of problem, just like this one. The hydronephrosis got hyperechoic content inside, so it's kind of pyelonephrosis. See, echogenic content. The urine should become black and echoic. We got echogenic content inside, so it's kind of pyelonephrosis. If that is blood, it should have dependent pattern. Then this is a situation. We can see the stone here. Sometimes you will not see the stone, right? And then we scan these patients. We scan the left side, hydronephrosis, and no obviously hydroureter. So when you are trying to figure out where it is the obstruction site, the most commonly the obstruction site should be UPJ, cross the iliac vessel and to the ureter. The iliac vessel is a little bit difficult to scan, so if I encounter hydronephrosis, I will scan from the kidney down the dilated tube. But if I don't see the hydronephrosis, I will go straight down to the bladder if the bladder is extended. So I scan for the bladder in transverse way. You can see here, this is the ureter from the medial posterior part into the bladder. Here we can see in hyperechoic stone. That because I have a good window. If urine is expelled, collected urine, so the bladder is collapsed, you have difficult to scan that. You can also use the urinary jet. Turn on the Doppler. As you can see the jet. That means that this side of the ureter is not complete obstruction because we got urinary jet from this side. And then the last part of my topic is painful and swollen scrotal. These situations may have different kind of problem you will encounter. This is the testicle of our normal skin. This is the testis, and the epididymis is a little bit smaller, just attached along the testicle, the longitudinal way, the transverse way. Again, homogeneous pattern. Use linear probe. Sometimes we can create different environment if you don't have linear probe, no Doppler functions, you can create a window. But if you are trying to figure out testicular torsion, you have equipped with linear probe with Doppler function, especially for the children, because it's even better if you got power Doppler, because the normally Doppler have two directions, right? Bright, blue and red toward red. But if you are trying to detect smaller, minimal flow signals, you have power Doppler can get better image. So we can compare each other to identify the problem is inside the testicle, epididymis, or around the structure. Just like this one, the testis, the problem is here, epididymis, very prominent swelling that you too easily to observe. And this one, when you turn on the Doppler, you can see the flow signals. That's normal. But in this picture, you can see the absence of flow inside the scrotum. If the scrotum is painful, you should be aware that this pain may be caused by the testicular torsion. When we scan longitudinal way, transverse way, and even better to compare with each other. And this kind of emergency situation, testicular torsion, you need to turn on the flow. And sometimes you will observe the swollen scrotum because of the drop the bowel loops into the scrotum. Sometimes the problem is caused by the enlargement, inflammation of the epididymis or even the testicles. Share one experience of our patient. 15-year-old boy got left side scrotum pain for 1 day. As you can see, this is because he is 15 years old. So I have the capability to use the curved linear probe to scan this kind of problem. The normal site got flow, not swollen. This one, hypoechoic, that means some kind of edema or ischemia, so it got swollen. No vascular signals inside. Remember this? No red or blue because I use power Doppler to detect even minimal flow. So the condition is testicular torsion, so the patient got all tectone because no flow inside. Okay, any questions for me for this topic? I keep the schedule, sorry. And then, the first talk and this talk, I use the recording system. So normally I will put my talk or even cases on my YouTube channel. So if you are interested, you can write down these kind of informations. After this talk, I will transform the lecture content into video type and then put on the YouTube. Alright? Then, this is the take-home message. We look inside obstruction and possible the obstruction cause the stone, no matter it is gallbladder system or renal system. And if you have the situations you will encounter testicular torsions, you have to find out some kind of resource in your equipment, or you will find where can provide the linear probe with the Doppler functions to resolve this kind of problem. If no more questions, it is my last slide. Okay, I will end here because I like to play the Iron Man. So Iron Man got the ending. Okay, thank you.